The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone. We want to welcome you this morning to our Safe and Calm webinar. This is Deanna Mitchell with Leading Age Michigan. As the pharmacy partnership program continues to vaccinate large number of our residents and staff, and we have seen a huge movement in that respect in the last week or so, we're also looking ahead to being able to better contain transmission in Michigan. Although we understand it will take a long time to get back to a real sense of normalcy, it looks like we might be trending in a very good direction. Caseload continues to fall in Michigan as we slowly vaccinate. With that, hopefully comes a little bit less member burden, fewer frequent and dramatic changes in regulation and guidance. And we're sure that you all, as well as us, would like to get to the point where a lot of the regulations decrease to the point where these webinars are really not needed anymore. So hopefully we're trending to a little bit less burden on our members. So today we are going to follow our routine agenda, starting with advocacy and a brief situation update. We're going to review and provide resources for all of the numerous vaccine updates and repostings that have come out. This morning, we're also going to review the HFA-AFC frequently asked questions. There are answers in that document to many of the questions that we still get. It has been recently updated, so we think that it's a good time to probably do that. And of course, we'll finish with a few miscellaneous updates. With that, I will turn the presentation over to Dalton Herbal, our Director for Public Policy. Good morning, Dalton.
Good morning. Good morning, everyone. I hope everyone's doing well today. For today, you can see it's Inauguration Day, so I found a little cool photo for us today. Our agenda for today, I'm going to share with you kind of who are the new quadrant leaders in the state of Michigan, so everyone can kind of put a face to a name. We'll talk a little bit about some consensus revenue estimating conference information that came out. Every year they do about 2 or 3 of these, and because of the pandemic, last year they did 4 or 5 because they needed to stay on top of the budget information. But this is where they estimate what the funding level will be for the budget process that usually begins in February. So legislative leadership will begin talking about what does the FY 21-22 budget need to look like in February. Then we'll just have some brief updates on the PRF reporting delays, and the HHS updated the PRF Phase 2 FAQ document to include some information about why some providers haven't received their payments yet. And then we'll cover our important date slide like we normally do. So as I said, we're going to put some faces to names here. Our Senate leaders haven't changed in the state. They were not re-elected in the last election, so we still have Senate Majority Leader Mike Shirkey. He's from Clark Lake, Michigan, which is the Jackson area. And then we have Senate Minority Leader Jim Ananich from Flint, Michigan. He represents Flint as well. So these are our Senate leaders. And then we have our new House leadership team. The new Speaker of the House is Jason Wentworth. He's from Clare. And then we also have a new House Minority Leader. Her name is Donna Lisinski. She's from CO Township, which is from right outside Ann Arbor. If you're from the area, I'm sure you know where that is. But they are our new House leadership team in the state. Moving on to the January budget estimation or consensus revenue estimation conference. They had some interesting numbers that came out in COVID, thanks to a mix of income tax withholdings, higher sales tax from online shopping, and federal stimulus payments. COVID didn't have a super drastic impact on last year's budget. It has always been projected throughout the entire process that the upcoming budget year would be the one where we actually saw the most impact from COVID, with some of that falling in the previous budget year. But they did note that last year's budget, or the one we're currently in, was actually only a 2% decrease from the budget pre-COVID in terms of total available dollars for the general fund and school aid fund. I do have the exact numbers there if you're interested. Now, as I said, in February, the legislature is going to be continuing to look going forward. And this had always been the year where COVID's impact was going to be fully realized in terms of the state budget. But they did have some good news to share. That revenue is estimated to be $874.8 million higher than previously expected, thanks to savings from this year and increased spending in terms of online shopping and some federal stimulus payments and unemployment benefits. It's important to note that also these numbers do not take into account any of now President-elect Joe Biden's policy initiatives that he's discussed at the federal level. So these numbers are clearly based upon what we have as of right now. In terms of the general fund, that'll be $504 million higher. The school aid fund will be $370.2 million higher. We still are facing a budget deficit for the upcoming budget, but it's not nearly as big as they once thought. Moving on to just some updates about the PRF portal delays. I'm sure many of you have noticed that the PRF reporting portal has been delayed, and HHS has officially pushed back the February 12th or 15th reporting deadline until further notice because of the delays. They also wanted us to let everyone know that they have updated some of the reporting requirements, and the biggest change is to how providers can calculate lost revenues for the funds. You now have the ability to compare budgeted to actual funds, or for providers to use any other reasonable methodology. And I put a bunch of documents here. I didn't want to cover every specific scenario for the PRF reporting changes. So you can see a summary of the specific reporting changes written by Leading Age National. I think they did a very good job. And then you also have the PRF Users Guide and PRF FAQ. Please feel free to go in and make an account in the reporting portal. That is open, you just cannot actually report. So I did include those documents there for you. HHS also updated the PRF Phase 2 FAQ. They really focused around, they must have been getting a lot of questions, and they focused around why have providers not received their payments for Phase 2 of the general distribution. They did note that they either did send it out and providers thought that one of the Phase 2 payments was not actually the payment, or that organizations with revenue greater than $5 million are required to set up an additional account, and that step had not actually taken place yet. So if you are a provider who is expecting payments of more than $5 million, please note that there is a phone number to help you set up this other account, and that you do need to set up the ACH account, and the provider support line is right there at the bottom for you. They also did tell us that they did require and request that a small number of providers resubmit data, but if they did ask you to do that, you should know who you are because they asked you directly. And then I put a link here to the currently updated FAQ. This has been changed since the November updates of last year, so it's not the longest timeline. So if you do have questions, please feel free to review the new updated FAQ. Onto our important date slide. You will note that the second draw PPP web submission portal is now open as of this morning, I believe, and for all providers, and then other providers it was open for last week. The next distribution of the PRF funds will be coming up in 4 days. They'll be going out over the week, but they did note that those will not all go out that week. They'll be working on them in kind of a batched manner until about mid-February. I believe we discussed that on our last call. And then the rest of it we've kind of covered. 228 is the end of the direct care worker wage pass-through payments, and then also the end of the $200 enhanced CRC payments until we either see an extension or we hear something further from the department about those programs ending. So those are our important dates.
All right, thank you very much, Dalton. Before we get into any questions, I just wanted to give everybody a quick reminder that you can go ahead and head over to the leadingagemi.org website and click on the events tab, and that will bring up our calendar of everything that we have going on in the near future. We do have our Finance and Strategy Day, part 2 of that series tomorrow, and you still have time to sign up for that if you are interested. And we also have a couple webinar series that we just posted as well, and they will be going for the entire year. So that would also be something to go ahead and check out and register for if you are in need. As of right now, we actually don't have any questions, so we can go ahead and move forward.
Thank you.
Thank you, Dalton. So we're going to take a look this morning at some of the national data along with our Michigan summary. I thought it would be a good idea to look at what the rest of the U.S. is doing since we had not done that for a while. So this map is from the CDC, and it identifies as of recently as this Monday, the average daily cases per 100,000 persons for the past 7 days. You can see that Michigan caseload is improving and fairly positive compared to other states. And we also note that there are several states that are in severe crisis at the same time. Here's a comparison of Michigan caseload since about midsummer, well, August. A comparison of Michigan to the U.S. in terms of daily new cases over the past several months. We are improving here from the huge surge that we had in November. Do note that the numbers are different from slide to slide, of course, because the U.S. numbers are going to be phenomenally larger. But you can see the trends over time. Across all states, you can see that there has been a slow incline through the holiday period, and hopefully that decline that we see in mid-January will continue in the U.S. overall as well as in Michigan. Here in Michigan, we have seen a rather dramatic decrease in the number of daily new cases over the past week or two. We're still not quite where we were in September, and definitely not where we were in June, but we are improving, and that's a good sign. Deaths are finally coming down as well, with continued sharp declines over the past few weeks, so that's an improvement. In terms of the CMS county positivity rates for Michigan, you can see that after a slight increase last week in the number of red counties, we are again coming back down and hopefully stabilizing. Last week, we only had one county that was not listed as level E by MDHHS, and this week we now have 6. So hopefully those trends will continue as well. Cases specifically in skilled nursing facilities declined also, but rather slightly. They seem to be stable since early January. They're definitely not seeing yet the same declines that the state is experiencing, but at least it is stabilizing somewhat. One thing that we did note, excuse me, was a sharp increase in the number of new cases at homes for the aged. We're not sure if this is just an aberrancy or something that an individual spike or maybe a reporting batching issue. We're hoping it's just a short-term thing. You can see that it did follow a decrease last week, so we're going to be monitoring that. Hopefully it will not only just stabilize, but start to come down. And it appears that AFC cases continue to stabilize. Again, it seems like the nursing home HFA and AFC cases are not declining as rapidly as the overall caseload in Michigan, but it might take a while for that to happen there in terms of outbreaks, because once an outbreak starts, sometimes it continues for a while. But we are very hopeful that these cases also will start to decline rapidly soon. These are the numbers from MDHHS that talks about just the current week and the cumulative numbers over time. You can see that we have just crossed the 40,000 mark in terms of total cases, and that includes staff and residents. And we've unfortunately experienced almost 5,300 deaths here in Michigan facilities between staff and residents. So one of the things that I added this morning was I wanted to have a short discussion about strain surveillance, since there's an awful lot in the media about the mutation of the virus. And we know that the CDC and other experts have been monitoring this closely. There have been a few different strains emerging in the US. We know that those strains are heavily emerging in other countries as well. So the link to the CDC review of this, what I'm referencing in terms of this discussion, is at the bottom of the slide. Apparently, strain surveillance is a critical factor in managing the disease. So with ongoing transmission, these viruses are always going to mutate to some degree. And the more that they're transmitted from person to person to person, the more mutation will occur until you might get a virus that is definably different from the source virus. So once they morph into a new virus, the whole game changes, or possibly changes. They could be different enough to produce either more severe or milder disease. They may not begin to be recognized by current testing methods. They may not be susceptible to our current antibody treatments. And very importantly, they may not be prevented by our current vaccines. However, that's not been identified yet, but that's why it's so important to monitor these. And that's why it's one of the most important reasons that you have to stop the transmission of the virus as soon as you can, since the more it's transmitted, the more likely it will change. And we can emerge with a whole different disease that might require different testing and treatment. And you can see from this slide here, and this, I think I said, is from the CDC, that Michigan has identified that the B117 variant has occurred in our state as well. Not to the degree that it's in others. And I think it's a very small portion right now, very small. But we are, the experts obviously, are tracking this and looking at this. So we're now going to move to our review of recent resources and guidance, and we're going to start with some CDC updates. So the CDC this past week issued a report that identified a large portion of transmission could apparently be as high as 50% from asymptomatic persons. People who are completely asymptomatic may be responsible for as much as 50% of the cases across the United States. So that means that precautions such as hand washing, social distancing, and masks continue to be very important in almost any social situation, along with testing of asymptomatic persons who may be exposed, and testing of persons who are staff in long-term care and healthcare settings. So obviously, being aware that just because a person looks well, we all know that they very well could be carrying the disease. Lately, it seems that either the CDC or MDHHS tweaks or updates these resources and guidance on vaccines almost every day. So I wouldn't be surprised if you all weren't overwhelmed with the amount of resources that are coming at you. Leading Age has also developed some summaries of these resources, specifically for long-term care facilities, obviously. They have produced a best practices guideline for vaccine clinics, and you can see the variety of materials that might help members here. Additionally, they are holding a webinar tomorrow afternoon on the legal issues related to vaccines, and that registration link is here on the slide as well. And the CDC and CMS will be holding a chat on vaccine safety this afternoon. The link to that is here. But also note that I think that's mostly about vaccine hesitancy, just to make sure you're aware. So Leading Age has ongoing conversations with the CDC, and recently they were somewhat pleased when the CDC provided a more clear definition of the pharmacy partnership program and who it applied to. Apparently, there was some information out there that some states were not including any kind of independent living in their plan. In Michigan, at least, that does not seem to be the case. But you will note that in the language that came from the CDC, standalone independent living is still not in the program. If you are associated with a CCRC, or if you are a Section 202 housing facility, you should be getting your vaccines at this point. But standalone independent living is still up in the air, and in Michigan as well. Although we have heard that health departments are, in some areas, vaccinating those housing and other kind of facilities, especially since the governor has decreased the age to 65 for the next group. Apparently, there's anticipation that the feds will be putting together an additional plan that will continue to rely on the retail pharmacy. We're not really sure what that looks like yet. Hopefully, we're hoping that that will include a defined plan for following up vaccinations for new staff and new residents. So we still don't have clarity from the state about how facilities are supposed to ensure that over time everyone continues to be vaccinated. Some are thinking that facilities themselves will have to arrange these vaccinations and perhaps even store the vaccine on their premises. But the state, again, has not been clear about that, and we think that that would be a burden. So we've asked several times about this, but they've not responded, and usually that means they have not yet made up their mind. So we're still continuing to put forward this topic for discussion, and we'll just have to see where that goes. And last, at the bottom of the slide, there is also a vaccine toolkit updated for retirement communities on the CDC website. So yesterday, the department put out another set of reminders, and I have pretty much included them here verbatim for your review. So the next 3 slides pretty much has a number of links. I really didn't see anything that I thought looked updated that much, perhaps a link to a new resource, but I didn't see anything really drastically new here. But I want to make sure that everyone has all of the links and resources that are out there should they want to look at it. There is a large focus on the importance of screening prior to vaccination, And one thing that is new is that the CDC has issued a new pre-vaccination checklist. And the link to that, of course, is included here as well. Remembering that there should be an interval of at least 14 days before or after any other vaccinations. And the full update link is at the bottom of the page. So this is the second page of all of the reminders that came out from the department yesterday. There are training modules on the CDC web pages about each kind of vaccine. That's not new. There is a best practice list for vaccination clinics, and we noted that in the leading age guidance earlier, and other resources here. This last slide completes the updated resources as issued by MDHHS yesterday, with details on the responsibilities for the pharmacy provider and other sources of vaccine information, including some resources from the Immunization Action Coalition. Yesterday, during the governor's press conference, she identified that with additional monies from Congress, she hopes to meet a goal of 50,000 vaccinations per day. The funding will also allow additional staff at local health departments to make that happen. And again, there will be more funding in Michigan to continue our testing plans. So about a week ago, MDHHS sent out a new emergency order. I think it was the 13th, but don't quote me on that, about testing and the specific requirements for hospitals, labs, and health professionals. Some of these changes in the guidance, if they are applied to us, they're extremely problematic for long-term care facilities. And we hoped that the state did not intend for these requirements to pertain to us. However, as it is written to include CLIA certificate waiver facilities, it does technically apply, since in order to do the tests, all of our nursing homes and some assisted living level facilities have had to be enrolled as a CLIA certificate waiver facility. So we've asked the department specifically about this, and we've also asked perhaps about getting a speaker from their testing group to come and explain all this to us, but we've yet to get a response. In general, the guidance reinforces the idea that testing entities must prioritize using the state guidance. But we didn't actually think that was much of a problem at this point. We thought that in general, people had access to testing supplies. The guidance also discusses information requirements, some vaccine requirements, and reporting requirements for hospitals.
Thank you, Deanna. Excuse me. Thank you, Deanna. As of right now, we actually still don't have any questions, so you can keep moving on.
Okay, good, because I want to move to the next slide, because I think the question slide, I think I put it in the wrong place, so I apologize for that, because I'm not done with the last topic. So the reporting requirements that we were just talking about, all tests are supposed to be reported to MDHHS via the Michigan Disease Surveillance System, no matter if positive or negative. Well, is that any different than the reporting that we do now? We don't think that there's an intention for that, but we would like to make that more clear. The reporting issues have been kind of messy between EM Resource and NHSN for quite a while. And of course, the other level facilities are only required to report to the state. But there are also information requirements. I don't think that they changed much about what you have to provide when you're reporting. There is some discussions about reporting vaccine information. And there was an additional piece about mandatory reporting of deaths associated with COVID within 24 hours. So there were several questions that came out of this that I thought were timely, that came out of review of that guidance. Is there really an expectation that the findings of all point of care tests completed by the facility be reported in 4 hours? We've let the department know that that's a very heavy burden, since unlike many other settings, long-term care providers test around the clock. Also, we want, as I said before, to clarify the nursing home reporting interface. And we think that this is a good point to also, again, ask for clarity about ongoing facility vaccinations. So those are the pieces that we're asking, at least about this guidance and these topics right now. And if there are any questions, let's pause here for a moment. And are there any other questions we want to provide to the state about these kinds of issues that we may have missed?
All right, I'll just give it a few seconds then for people to respond and then see if we got anything. RIC Preventionist tried to set up access for reporting to MDSS. MDHHSS maybe?
Probably.
And each person has to have their own login.
Okay, I'm not sure. I'm not sure what platform they're reporting to. I'm not sure what that actually means. That's part of the question that we have to try and figure that out. If this is a new place that we have to report to, I am not clear about how that works and how that relates to EM Resource and NHSN. Now, since all of you are still reporting, you may actually know more about that than I do. So if this is a good time to talk about that, if indeed that's the case. So we'll give you a couple more seconds to respond. Blake, anything else?
So she followed up and said MDSS is different than MDHHS.
Oh, okay. All right. So that's a reporting system.
Mm-hmm. And then if we do have to report positive results within 4 hours, where would we report this information? To NHSN or Health Department?
That is part of the question. I don't think it's NHSN. They don't have that reporting time requirement. I think it's to the Health Department. I think it's to EM Resource. The Health Department's not open 24 hours a day either. So that is part of the piece that I think that we need to have more clarity about. I would like to talk about the whole reporting thing and get some better understanding of it keeps morphing back and forth. And to be honest with you, I'm not sure what everybody's supposed to do anymore, and I'm trying to track it. So that is one of the reasons why we are requesting that we get a speaker from the state to talk about this clearly. But at this point, all I know is pretty much that it's a possibility that they've changed it again.
Are HFAs required to report all tests done other than the weekly Qualtrics report?
That's what I don't know. I do not know that. The emergency order says all CLIA certificate waiver facilities. And if you're doing point of care testing, you have to hold a clear waiver certificate. So to me, it looks like it applies to you. I'm not sure that the department really intended this, and that's what we're trying to figure out.
The 4-hour reporting says to do it to Michigan Disease Surveillance System that requires a login, so all our staff would need to get one. So that
right. So it looks like you would have to do your normal reporting in this additional surveillance system. And it just seemed burdensome and duplicative, and we're wondering if that's really what the intention was.
Is there clinical guidance about who is included as a COVID-associated death, or is this up to the attending physician to determine?
my understanding all along that it is up to the attending physician. I do know that for cases that they're not sure of, the public health department, the state public health department, looks at death certificates to see if there's any possibility of a COVID-associated death that isn't identified as so. But I think at your level, you would not be able to anticipate whether or not a death was COVID-related without a physician defining it so.
My understanding is the information we submit in the EM resource is placed in the NHSN and is covered in it and covers all of the required reporting. Is this correct?
Yes, that's my understanding at this point. As long as you have gotten all of your contact information and let the state know that you want them to submit the information for you. I had thought that there were also for a time some additional NHSN information, but I think that's changed. I think currently the state has updated everything. So my understanding is that if you're using EM resource according to the rules that are there, and they have been sending out updates to that weekly with a reminder that you must report, so that if you're doing all of that, you should be okay. What we don't know is whether or not you have to also report to this additional surveillance system, which makes no sense to me.
I received access to the Michigan, sorry, it keeps moving, the Michigan Disease Surveillance System and have no idea how to enter the information into this system, let alone within 4 hours.
Right. And that's the other thing is that we just have not gotten enough information. And what I'm hoping for is that it was not their intention for long-term care facilities to do that. But we will have to see. We will really have to wait to confirm this with the state.
The first paragraph states CLIA waiver facilities that process tests. I took that to mean the labs, not us.
Well, and that's a possibility. I don't think that's clear though, because CLIA waiver facilities, you as a CLIA waiver facility are processing tests. Now, I could be wrong about that. I would hope that I'm wrong about that, and I'm not sure. So I just wish the state would come back and be more clear.
We POC tests approve visitors and would need to get a lot more personal info from them for the reporting.
Right, that's true.
Has anyone put information into the Michigan Disease Surveillance System? I could not figure out how to input information. So another issue with that. But EM resource reporting is now done weekly, so we wouldn't meet the 4-hour requirement.
Exactly.
Our understanding is that it is considered a COVID death if a resident dies within 30 days of a positive COVID test.
Oh, okay. If you would shoot me an email and let me know your source for that, I would be interested. Obviously, there's so much out there, but I would like to see that as well. Thank you.
I'm assuming this is for the Michigan Disease Surveillance System, but they said it is very clunky. You have to open a new case investigation. And she says,
Wow.
I have open new case investigation and I made a form to collect the info from visitors I can share if needed.
Oh, that'd be helpful. If you shoot us an email, that'd be great. I'm still hoping we don't have to do it though.
All right.
Blake, I think, are there specific questions, or I'm wondering if we should move on?
It looks like that was the last one anyway, so we can go ahead and move forward.
Okay, thanks. Okay, we will try and sort through that mess. This morning, I thought it would be a good time to review the HFA AFC FAQs. The document, which was created many, many months ago, has morphed a lot. especially recently, and many of the areas have changed dramatically over time. So with these recent updates, we thought it would be a good idea to simply do a quick review of it overall. It's important to note also that in general, the rules that apply to HFAs and AFCs come from the same rules that apply to nursing homes. So some of the things in here, such as fingerprinting and things like that, they apply to nursing homes as well. There is, of course, guidance specific to HFAs and AFCs and how they are managed and the type of persons that they have as residents, but much of this does apply to all long-term settings. So the first piece is residents always have the right to leave. I do actually still get some questions about that. They do state that clearly in the guidance, with the idea that facilities should discourage it, however, and remind residents and families of the appropriate safety precautions. Facilities must screen on return, and they can place the person in quarantine if there's reason to think that they've been exposed. However, I think later in the guidance, they actually say they suggest a physician order to do that or an order from the local health department. For persons with symptoms, obviously, if they need medical attention, the facility should call 911. It's important to note that EMS staff have been trained and now have the ability at this point to try and treat in place. But basically, that rule was created to address the large number of responses to facilities who simply identified that a resident was positive, often with no symptoms. They just felt that they could not adequately isolate the person in their facility. So EMS at this point will only take the person to the hospital if they need acute medical care, because the hospitals are getting overrun. If there are symptoms but they're not acute, you should contact the physician for guidance and get an order for testing. You can test, and remember that you can take an order from any health professional for a test in Michigan. And MDHHS will say that you must test if you have someone with the symptoms. And if you find a positive person, you again must test everyone in the facility, residents and staff. Here the guidance states that you should follow the CDC guidance about precautions for a positive resident. And we think at this point everyone should pretty much have a plan for isolating, cohorting, or whatever at all levels of facilities to protect others when there's a COVID positive person in the facility. You will see slightly different protocols based on where it's coming from. There are like 4 or 5 different state agencies identifying protocols for what to do, especially in HFAs and AFCs. But in general, the expectation is that you follow CDC and MDHHS guidance on isolation, and with the link to, that I think is coming up a little bit later, the link to the CDC guidance that they felt was pertinent. And remember that EMS may help you form a plan to treat in place if needed, and that EMS workers do not have to be screened on entering your facility. Here is the link to the suggested guidance for care of COVID positive persons or persons suspected of having COVID, and we consider that pretty much the best guide. And remember, you have to have an order from someone to isolate or quarantine. This language about readmitting persons who are COVID positive from the hospital has been in the document for a long time, and it includes information needed to ensure that you can provide a safe environment for a COVID positive person. So if the person does not meet the criteria for discontinuing precautions, in other words, they're still considered infectious, you need to really consider your ability to serve them. Look at your staffing, look at your PPE, and your ability to isolate within your physical structure. The guidance implies that you should consider all of that before deciding to take the resident back. But note that the hospital is required to ensure a safe discharge. Overall, there is an expectation that you try to take the resident back. There's no question about that. The licensing rules for reporting for cases in HFAs and AFCs are a little different from one another. Apparently, HFAs must submit an incident report if a resident suffers or is at risk for more than minimal harm, and the state considers that a person infected with COVID would meet that criteria. There's no standard reporting needed for AFCs, but guidance from a separate MDHHS group that's working on guidance for AFCs states that you should inform your licensing officer of any cases. Again, everyone must report positive staff to local health department within 12 hours, or it may be 4 hours if the rules are changing. We're not sure still. The jury is still out on that piece. Remember that communal dining and group activities for these settings is the same as the CMS guidance for nursing homes. It essentially says that you can have communal dining and other activities as long as you're providing all the routine precautions, mainly social distancing. We do still get some questions about this, and several members have been applying the emergency order rule. And I don't remember what date is assigned to that rule. I think it's the last gathering order. Anyway, it limits gatherings in residential settings to 10. It's our belief that that guidance is intended for individual residential homes in the community. It was intended to identify the number of persons who would gather mostly safely over the holidays. It doesn't really apply to facilities for maintaining precautions. So it's our understanding that you can limit the number of persons in a dining room. You have to, but it's based on space requirements. You don't have to limit it to 10. So yes, you can do communal dining and group activities as long as you maintain those safety spacing precautions and social distancing. In terms of staff issues, we continue to get several questions about these kinds of things. Fingerprinting is no longer waived. We have included a link here to the LARA page that discusses it. CPR recertifications are currently required. The FAQ says that if you are having trouble testing, you should contact your licensing consultant. There is an understanding with licensing consultants that there could be delays in getting all the pre-employment paperwork completed for a new hire. But if you haven't gotten it all done, they will understand that if you haven't gotten it done in advance of employment. But you are asked not to leave the staff alone with residents until you're pretty much complete in that respect. You can postpone pre-employment physicals, and for the time being, you can use telehealth to do that. But the physicals are expected to be done as soon as possible. Fire inspections have resumed. They've been resumed for quite a while. They understand that vendor testing may be delayed. They also know that fire drills may be modified for areas where there are persons in isolation. So obviously you're not going to do a fire drill for that area. But you do have to have fire drills for other areas. And depending on how you're structured, if there are staff who are dedicated to isolation areas, they should not be doing drills, but it is required that you show how you have trained them specifically to ensure they're up to date on fire safety. The next two topics in the FAQ are pretty new. I'm sorry, yes, go back. They cite the emergency guidance on activities that can be allowed. Can you use a pool? Can you use an exercise facility? The answer is yes, according to LARA, as long as the occupancy requirements that are in some of the emergency orders are maintained. But we found this kind of challenging. Remember that you're supposed to try and keep social distancing, and we were a little surprised to see that these elements would apply to long-term care facilities. But apparently, Laura is applying them, and so these activities are allowed. But at the same time, you have to ensure that your residents are safe as well. So that completes what we got today. Again, we will follow up with the state to try and figure out that testing reporting rules and get that out to you as soon as we hear anything. Any final questions?
All right, thank you, Deanna. We do have a few, so I will just get right to those. Any idea what criteria Michigan is using to determine risk levels in the Safe Start map? The numbers look so much better, yet everyone is still categorized as an E.
Yes. The answer in terms of the definition for how they create, the methodology for how they create those risk levels is not fully published. I do know that they look at a huge number of factors, unlike the simple county positivity rates that CMS uses. They use the transmission rates. They use the hospital capability. In other words, if your hospitals are full, caring for COVID positive persons, that impacts your overall risk level. So I think that there's like 5 or 6 factors. I have to go back and see what they are in general, but the methodology for them is not reported. I believe that U of M calculates this, if I'm not mistaken. And there is some definitions off the MySafe, well, there's a description off the MySafe Start map page, but it's not clear. It's not clear at all what the methodology is. And I've never known what it was specifically, sadly.
What about a new admit that recovered from COVID a month ago? Do we need to admit as a PUI for 14 days? They aren't tested for 3 months, so if they are within that 3-month window, would we just admit to a regular room?
This has come up a lot recently, and we have always provided guidance that you do not have to quarantine those persons. However, we do know that there are a lot of facilities who are. And I guess it depends on how you want to look at it. There is nothing in any guidance that we have read that specifically says you don't have to do that. But when you look at the definition of people that you're supposed to isolate, obviously you have to isolate anyone who's COVID positive. And for people coming into the facility and not someone who is specifically known to be exposed, the persons coming in are called COVID unknown. Well, our interpretation of that is that people who have had COVID in the last 30 days are not COVID unknown. We know what their COVID history is, and we know that they are recovering. And they should, if they're beyond the need for transmission-based precautions, it was our interpretation that you wouldn't need to do that, especially considering that we all know that 14 days of isolation is not good for anyone, or quarantine technically, but not good for anyone. So we don't have a 100% clear answer. I do know that there are some facilities who continue to do that. I think that at this point it's an independent judgment. It's one of those scenarios that isn't clear. We will ask the department what their thinking is, but maybe perhaps a better idea is to ask the CDC. But to be honest with you, they tend to be a little bit, in some respects, they are more programmatic and with routine protocols in the department, detailed protocols for the department, but in some ways they're not as strict as the epidemiologists in the state. But we can investigate that further.
Is there a clear way to determine whether the resident requires a 10 or 20-day isolation and TBP after COVID positive test? The CDC lists factors such as being very ill with COVID or immunocompromised, but it seems difficult to know when to use 20 days instead of 10 days for TBP and isolation.
I really think that that's not a decision that the facility itself can make. I think that that needs to be a specific clinical medical decision from someone who is either the attending physician or an infectious disease consultant, and if necessary, a consultation with the local health department. Each local health department has a medical director that is supposedly trained in these sorts of things. Yes, the CDC does not identify the criteria for that. It is a medical judgment, however, and I think that you're never going to get A, B, C kinds of criteria for that. You're going to have to rely on a professional.
Today is the end of the waiver for CNAs to work who have not passed their test yet. Do we know if this will be extended?
Okay, so I'm assuming that's an 1135 waiver that says that the test may be Let me look into that. My head is telling me that there's also some other guidance about CNA testing in Michigan. So let me look into that, and I'll try to put it in a member update later today or tomorrow.
We reached out to a surveyor regarding quarantining recovered COVID residents, and she said she didn't know for sure, but said to cite your policy for discontinuing transmission-based precautions for not quarantining them.
And that makes sense to me. I do believe that it's one of those areas that's very gray, and I would think that there's nothing that stops you from not quarantining those persons as long as you're following a reasonable rationale and it's in your policies. But if the question keeps coming up, I mean, we certainly ask the state. Sometimes you don't want the state's answer also. But we can look into it further.
We have heard of some resident staff testing positive directly after their 90-day pause on testing. We have also heard the CDC is considering extending the 90-day pause on testing. If a resident staff tests positive on the 91st day with no symptoms, what should be our course of action?
Well, I would think that you should consult. They have no symptoms. I would still consult their physician and or your medical director, your occupational health team and or the local health department on that. I would think that the difference between 90 days and 91 days isn't very long. I don't know. I've not seen the science behind the fact that some people can continue to test positive after 90 days. I haven't seen anything about that at all lately. So I'm not sure where the science is, and I would not think that someone who's asymptomatic at 90 days is probably infected. But part of the dilemma, I think, with this virus is that it is so highly contagious. And one of the reasons why persons are supposed to use masks after they become vaccinated for a long period of time, as long as there's local transmission, is that because people can still carry the virus in their nose even if they don't become sick. So it's possible that someone who was previously COVID positive could still have come in contact with someone who could have transmitted to them the virus, and it still could be in their nose, but not become sick. So I guess we'll have to look into that, but I would suggest you consult with a medical professional.
All right, thank you, Deanna. As of right now, that actually looks like it was the last question. So if you do think of anything after this webinar has concluded, as always, you can fire off an email to Safe and Calm, Deanna, or Dalton at leadingagemi.org, and we will make sure to get any questions that you have answered. So with that, we would just like to thank Deanna and Dalton, and we would also like to thank the 95 members and participants that took time out of their busy schedules to join us for today's webinar. We appreciate everything you do each and every day to support your staff and provide quality care to your residents. We are grateful for your continued support, and we are here for you when you need our assistance and resources. Again, just a quick reminder that we will not be having a Safe and Calm webinar on Fridays still, and so our next webinar will be Wednesday, January 27th. So with that, I hope everyone has a great remainder of their Wednesday, and we will see you all soon. Thank you.
Have a good day, everyone.
Take care.